Buenas tardes, bienvenidos al tercer módulo de la mañana. Los saluda Ignacio Hanna. Quiero aprovechar para agradecer a la organización del Congreso por la invitación. Es un evento que está teniendo un nivel científico altísimo y estoy muy agradecido y muy contento de formar parte de este evento. Quiero darles a todos la bienvenida y darle el paso a Sofía Villar, con quien vamos a moderar este módulo.
Muchas gracias, doctor Hanna. Muy contenta de participar en este tercer módulo con profesores internacionales. Y bueno, quisiera presentarles al primer ponente, es el doctor Marc Pimentel. Él es director ejecutivo del programa de Ciencia y Tecnología Médicamente Asociada, MAST, por sus siglas en inglés, en el CIDARS Sinaí. Y él nos va a presentar todo lo que debemos de saber de SIBO, IMO y SIFO. Doctor Marc, please.
Well, thank you for inviting me here to this amazing conference, and I'm very excited to talk to you about SIBO and IMO and SIFO and maybe ISO. We'll talk about a number of things today. Yes, thank you. So what I want to start with is that you have to remember there are many causes of small intestinal bacterial overgrowth, but the problem with this term, small intestinal bacterial overgrowth, is it implies it's only bacteria. And so we're going to talk a little bit about SIFO as well, as you'll see as this unfolds. But there are many causes. Anything that delays the transit of the small intestine, leaves the small intestine with the possibility of overgrowing or being contaminated with material or bacteria or archaea or even fungi, as we'll talk about. And so you could actually look at this as overgrowth syndromes, where maybe H. pylori is there, but it doesn't cause disease, but when it's high, it does. C. diff, you find it in the stool, but it's not causing disease, but when it's overgrown, it causes illness. And perhaps in the small bowel, there are equivalents, which we'll get to in this conversation. But this is not classic SIBO that I'm going to talk about today, because as we've learned more and more and more about SIBO, is that it can happen even in the naive abdomen, or the person who has not had surgery, not gastrectomy, not Billroth 2, not malabsorption, and that the other myths are methanogens are only in the colon. We now know that's not true. I'll show you a slide later. And that SIBO is the movement of the colon flora into the small bowel. Shotgun sequencing now shows that is not how this works. That is not what's happening. Even though there are coliforms, it's not that there's movement from the colon to the small intestine. We spend a lot of time learning about SIBO through IBS, so I will try to bring this into the forefront so that you understand how IBS and SIBO interplay, but then get to the different types of SIBO. But perhaps there's a percentage of IBS that is SIBO, a percentage of IBS that is bile acid diarrhea, and others. And what I'll show you at the end is now there's some consensus on this, that this may be the case, that a proportion of IBS is one of these disorders. But to get to the true root, what is the true root of alterations in the microbiome in IBS? Maybe it starts with food poisoning. You could argue today that we know more about at least a portion of IBS, the inciting causative event, than we do IBD. We don't know what triggers Crohn's disease today, and then the patient comes in a month later with ulcers in their colon. We know they have genetic predispositions. We know there are environmental predispositions. But with IBS, there's 49 outbreaks here, and the chance of developing IBS is 1 in 6.9 if you get food poisoning with either Campylobacter, Salmonella, or Shigella, or one of those types of pathogens. But look at Campylobacter. 20% of people who got Campylobacter develop IBS for an indefinite period of time. So food poisoning is a major cause of irritable bowel syndrome. But what we did over a period of about 10 years is we tried to understand if there's a pathogenic process here. Could there be a relationship between IBS and changes in the microbiome? And one of the toxins we discovered was cytolethal distending toxin, which is the only toxin produced by all 4 of the pathogens classically known to cause IBS. What we then learned is that the CDTB toxin allows you or promotes you to form an antibody to it, but then that antibody is similar, it recognizes a similar sequence in vinculin. We now know the sequence in CDTB, we now know the sequence in vinculin where this homology occurs, and that's for another talk maybe next year, because we have a lot of data coming out on finding the cells that produce these antibodies. But if you use these antibodies, you can actually identify IBS over IBD for the first time. You can be able to tell a person in your office has diarrhea, they come to your office, you do the test, if it's positive, you have IBS. So it's a way to identify IBS, not to rule out something else. Fecal calprotectin, if it's positive, maybe you should scope, maybe they have IBD. That's not telling you they have IBS, that's telling you they don't. This is a rule in. And I show this slide because this is the sensitivity and specificity of this blood test. But look at the sensitivity, it's 56%. So people say, well, it's not sensitive, so it's not good. The specificity is fine, it's 90. But remember, this is using the test to diagnose IBS. But not all of IBS came from food poisoning, maybe 60%. So if 60% of IBS is from food poisoning, 56% is very good. So we just don't know because these patients may have had the food poisoning a decade ago and they don't remember. But if you give this toxin to rats and you inject it into their back twice as an initial immunization and a booster, they get changes in the antibody, of course, on the left. They get increased water or wet weight that's proportional to the antibody, and they get a change in the small intestinal microbiome. So I want you to think about this again. We inject the toxin into the back, under the skin. They develop the antibodies, and they develop a microbiome change in the small bowel. I'm not showing you the colon because the colon was no different. The microbiome was no different. And it ended up in 3 clusters. One cluster is no different. You got food poisoning, nothing happened, you didn't change. But there were 2 clusters that were identified, an E. coli cluster that was elevated and a desulfovibrio cluster that was elevated, suggesting hydrogen or hydrogen sulfide producing organisms in the small intestine. So now let's take that to humans. Now we have breath testing. This is a breath test meta-analysis in irritable bowel syndrome. And so if you compare IBS to healthy controls, 15 of these studies are high-quality studies, according to this group from Australia. And you can see that IBS has more positive breath tests than healthy controls. This is a phenomenal study that just got published because it's a study where they took healthy people, they took people with classic reasons to have overgrowth, whether it's a Billroth 2, adhesions, real people who should have overgrowth by the classic definitions. And then they took a group of IBS patients. And what they found was that there were 2 groups, people with high hydrogen and people with low hydrogen. And the percentage of high hydrogen in the classic patient with overgrowth was the same as the percentage of patients that were high on the breath test who have IBS. But they partnered this with transit study using HIDA. And they were able to say that this breath test happened before the colon. And so they were able to show that. And when they treated all the IBS patients with antibiotics, all of them, regardless of the breath test, it's only the high hydrogen patients that responded. So this is a very important study, and you should probably read it. But if you do culture of the small intestine, there's 2 studies from Europe showing that IBS patients do have excessive coliform bacteria in the small intestine. If you do 16S ribosomal RNA assessment of duodenal aspirates and compare that to breath test, the 20 part per million time point does pretty well with an 84% specificity. The sensitivity is 57. But it also correlates with the types of bacteria that produce hydrogen, specifically gamma proteobacteria. But I want you to focus on the last 2 columns. It correlated with the metabolic function for production of hydrogen based on the predicted bacteria in the small intestine. Put a pin in that because we're going to show you some more information on how the breath test correlates with the small bowel microbiome on shotgun sequencing. So this is 16S. So we've gone from breath to 16S, breath to culture to 16S, and then to shotgun sequencing. But before we go to the shotgun, The problem with breath is that there are 3 gases that are produced by the bacteria. I already mentioned hydrogen sulfide might be one of the byproducts, and we saw that on the animal study. So now there's a 3-gas breath test that measures hydrogen, methane, and hydrogen sulfide. And as I'll show you in a minute, hydrogen sulfide actually correlates with diarrhea severity, and methane correlates with constipation. So you have to measure all 3 gases, and it is a pitfall of traditional breath testing without that 3rd gas. Now I'm going to talk about shotgun sequencing of the small intestine. This is one of the first studies in history, shotgun sequencing the small intestine, period. Most of the studies were done in stool. And what we see here is this is not coliforms moving into the small intestine. SIBO is not that, at least the SIBO we're seeing in these intact GI tracts. SIBO is 2 organisms. Your entire microbiome now of the small bowel is 18% Klebsiella pneumoniae and 28% Escherichia coli. 2 species have taken over the small intestine. And these are Ferraris for producing hydrogen and gas production. And there's another slide which I've taken out for the sake of time, but shows that patients who have SIBO, and let me take a step back, because in the Reimagine study, we can identify SIBO so easily because it's so dramatic because of the rise of E. coli and Klebsiella that we see. It stands out above all the other microbiomes. Now, using 3-gas breath testing, this is the first study ever, considering breath testing has been around for 40 years, where breath testing is done, sequencing is done, and the patient has IBS and they might have C or D. And so what you can see here is if you're a D patient in these registered trials with the FDA where these patients were being enrolled for drug studies for D and C, D patients don't have methane, but C patients do. And that's what the methane looks like on the red line. The D patients have hydrogen that reaches the 20 part per million threshold on average. Some, of course, don't, are below, but on average are above. And look at methane. Methane is below the constipated patients without methane, because when methane is there, the methanogens consume hydrogen to make methane. So it's important you understand how these gases work. And then hydrogen sulfide is higher in IBS-D. But we now are knowing who the characters are. The methanogens here are M. smithii, Methanobrevibacter smithii. Not only did the breath test suggest that there was more methane and predict constipation, it correlated directly with the quantity of M. smithii by qPCR in the intestine. So meaning the breath test is quantitative to the microbiome in the case of methane. Now, this is a study we presented at DDW 2024. This paper is now officially published, but basically the methane on the breath correlates with the methanogens in the small intestine. So breath was done today, scope was done today, aspirate was done today, and you can see that the methanogens, there are methanogens in the small bowel is what I'm saying. And that methanogen predominantly, if you look at number 5, 63% of the time it's Methanobrevibacter smithii again. But methane is an interesting gas because it's associated with slow transit. If you put methane into a live animal model of transit, this was a study we did in 2006, you get slowing of intestinal transit, but you don't get it by paralysis. So in the guinea pig ileum in vitro model that we have here on the right, you can see that peristalsis or peristaltic contractions are very natural in oxygen, but as soon as methane is put in the bath with oxygen, you get hyperperistalsis or hyperactivity. And actually we see segmental contractions when we did that study. So methane is causing spasticity of the smooth muscle of the gut. And now there's a meta-analysis that shows that when methane is present, you're more constipated and you have less diarrhea on the right. There's a study from Stanford here doing wireless capsule measurement of transit, and you can see that colonic transit time and small bowel transit time are delayed if a person has methane on their breath test. The same thing was done for hydrogen sulfide. Hydrogen sulfide measured or breath measured, scope was done, aspirate was taken same day, and hydrogen sulfide correlated with hydrogen sulfide producers in the gut. Once again, the breath correlates with and proportionally to the hydrogen sulfide producers in your small intestine when you do these measurements. This is a 6,000 patient study. It's not 6,000 patients here. The 6,000 patients got the breath test at their house, a 3-gas breath test. 3,200 or so patients returned the breath test and had a perfectly completed questionnaire. The higher the hydrogen sulfide or the higher the severity of diarrhea and urgency, the higher the hydrogen sulfide was. So hydrogen sulfide in real world use of breath testing correlates with diarrhea. We've now done transcriptomics in patients with high hydrogen sulfide on their breath, and then in an animal model, gavaging animals with 2 types of hydrogen sulfide producers to produce hydrogen sulfide in their gut, and the transcriptomic pathways activated in the small intestine are the same. And you will recognize some of these pathways as pathways that are important for motility, nociception, fluid homeostasis like aquaporins are changed. But E. coli, which doesn't produce hydrogen sulfide, did not do that. So hydrogen sulfide is becoming a very important physiological gas for the small intestine. So now we're left with 3 microtypes based on this information of, you could call it SIBO, but they're microbial overgrowths. You've got SIBO, you've got ESO, which is intestinal sulfite overproduction, and EMO, which is intestinal methanogen overgrowth. And the terms are given because of the location of these organisms are. Now, this is an important study from Cork, Ireland, and in the stool there is a shadow of all of this that's happening more clearly in the small bowel. I'm not going to get into all the details, but suffice it to say that John Cryan's group took every bit of data ever published on the microbiome of IBS in stool on the left, and showed that there were 2 characters that were outspoken in the microbiome dictating symptoms. One of them was Fusobacterium, which we found in the stool of IBS, which is a hydrogen sulfide producer, and E. coli. And so they are elevated even in stool, but to a lesser proportional degree. On the right is rifaximin. So rifaximin worked, and you can read the paper, by reducing a number of organisms, 2 of which are E. coli and Fusobacterium, in order to see the benefit of rifaximin, and that the microbiome more normalized after rifaximin as a predictor. So we know rifaximin works for IBS, but rifaximin is predicted to respond, patients are predicted to respond based on the breath test. So the higher, or if the breath test is abnormal, you're more likely to respond to rifaximin than if the breath test was negative, where you're less likely to respond. So the breath test is predictive. There's now a meta-analysis of rifaximin in SIBO, so this is not IBS, this is just SIBO, showing that it is effective. There's a meta-analysis of SIBO in IBS, that if you have SIBO in IBS, you're more likely to respond to antibiotics in general. And then there's this study looking at methane. Methanogens are not bacteria, so antibiotics were not designed for methanogens. However, rifaximin and neomycin in vitro showed good effect against methanogens, so we tested it in this study and showed that combining them seems to improve constipation more than neomycin alone, an active arm. Now we have an elemental diet, which will be spoken of a little bit more later in this meeting, later this afternoon, but elemental diets, starting in 2003, we did our first study with Vivanex. The principle was that maybe it's starving the bacteria out because it gets so absorbed so quickly, and maybe that's too simplistic, but what we do see is before and after elemental diet, these gases go down dramatically, both methane and hydrogen, and this is a palatable elemental diet that is now available for some patients. But now I want to spend the last few minutes of my talk kind of taking all this information, and I gave you a very, very quick and concise look because there's a lot to talk about now. But this is the Indian consensus statement on irritable bowel syndrome. And now this is a couple of years old, but it had the ability to look at some of this more contemporary data that I'm showing you here today. Statement 1, IBS, maybe you should look for SIBO, grade A recommendation. Excessive methane is associated with CIBS, level 1 evidence, grade B recommendation, and food poisoning. You should think about that in irritable bowel syndrome as a grade A recommendation. So guidelines and consensus are starting to take note of this. In the last couple of months, there are now 2 studies talking about maybe we should move to biomarkers of IBS, and SIBO and antivinculin testing and bile acid evaluations. All of these things are finding plausible pathophysiological and important things that might be happening in IBS that we could do something about rather than just always treating symptoms, because that's what we've done all along. And these are some of the tests that were recommended in one of the papers. I have one slide on small intestinal fungal overgrowth, but small intestinal fungal overgrowth does occur. It occurs in a small percentage of patients. It's the only diagnostic approach you have for fungal overgrowth is duodenal aspirates. And when you do a duodenal aspirate, please use a double lumen catheter because just too much contamination otherwise. Treatments can have benefits. We've seen that. And Satish Rao will be here at the meeting. He can give you his perspective. But most of the time, in a study we did using shotgun sequencing of the small bowel, when we see SIFO, it's Candida albicans, almost all the time. So in conclusion, IBS is a disease, not just a syndrome. There are now biomarkers that we're seeing in this. Food poisoning causes a significant proportion of IBS, and you could argue is a pathophysiological start of IBS. Antivinculin and anti-CDTB can diagnose and risk stratify these patients. We now have breath testing validated in more ways than history. We have it validated against shotgun sequencing, and if you go to DDW, it will be validated against quantitative shotgun sequencing, and it will be validated against aspiration of gas from the duodenum. So stay tuned. We're not done. We're going to continue to prove that the breath test is really important. And new types of gases are important. So I'll leave you with one thought. New drugs are also coming because we know the bugs that are causing these 3 different subtypes. Thank you.
Muchas gracias, doctor Marx.
Muchas gracias, doctor Pimentel. Nuestro próximo expositor es el doctor Max Mulson. Él es profesor titular de Medicina de la Facultad de Medicina de la UNAM, jefe interino de la Unidad de Medicina Experimental, doctor Rui Pérez Tamayo. Es responsable del Laboratorio de Trastornos Neurogastroenterológicos de la misma unidad. Es miembro del Board Directors de la Fundación Roma y es actualmente tesorero de la Sociedad Latinoamericana de Neurogastroenterología. Bienvenido, Max.
Muchas gracias, doctor Hanna, por la presentación. También agradezco al doctor José María Remestroche, presidente, y a todo el comité organizador por esta presentación. Voy a tratar de hacer una revisión de lo que es el abordaje integral de la distensión abdominal, pero enfocándome en México. Y espero que consideren eso para la presentación. No sirve. No sirve. ¿Me pasan la siguiente, por favor? Y si me pueden dar un apuntador. Ya, listo. Entonces, hay que recordar que hay 2 síntomas, quizás uno se puede considerar además un signo, que son la distensión subjetiva y la distensión visible. Los dos pueden coexistir o pueden estar presentes cada uno de manera individual en cada individuo. Y quiero empezar con este estudio epidemiológico que acabamos de publicar, en el cual participamos y se publicó apenas a principios de este año, haciendo un estudio poblacional por internet entre Estados Unidos, la Gran Bretaña y México, utilizando un cuestionario sobre la presencia de síntomas relacionados con gas en las últimas 24 horas. Y hay que tener en cuenta que el 89% de los encuestados en esta población general reportaron algún síntoma relacionado con distensión. Interesantemente, si ustedes ven arriba, los sujetos en México tenían casi el doble de reporte de estos síntomas relacionados con gas, y esto se asociaba a una disminución en la calidad de vida, aumento de ansiedad y depresión, visitas al médico y uso de medicamentos. En el mismo estudio se analizó específicamente la distensión abdominal subjetiva y visible, y cuando se compara entre los 3 países, la distensión subjetiva fue igual de prevalente en cuanto al reporte que hacían los sujetos encuestados, pero la distensión abdominal visible, ustedes pueden ver que fue significativamente mayor en aquellos en México. La presencia de la combinación de ambas fue casi el doble, y la presencia de distensión subjetiva o visible, cualquiera de las dos, también fue casi el doble entre las dos poblaciones. Lo que nos hace pensar que probablemente estos síntomas son más prevalentes en nuestra población que en otras poblaciones. ¿Me pasan la diapositiva, por favor? A raíz de que nosotros no tenemos una palabra o un término en español para expresar la distensión subjetiva denominada bloating en español, o la distensión como tal puede resultar un término muy técnico que los pacientes no pueden entender, nosotros hace algunos años diseñamos estos pictogramas, y este artículo lo publicamos en el 2022, basado en 2 estudios que realizamos, uno en pacientes generales de una consulta de gastroenterología y otro en pacientes específicamente en síndrome de intestino irritable. Y ustedes pueden ver que cuando se utilizó los pictogramas, pueden ver que la presencia de cualquiera de estos síntomas fue significativamente superior en este área bajo la curva entre los pacientes con gastroenterología, y fue casi perfecto entre aquellos pacientes con síndrome de intestino irritable que presentaban estos síntomas. Posteriormente, como parte del estudio global de Roma 4, también aplicamos estos pictogramas en la población general de nuestro país, encontrando que el término inflamación era el más utilizado tanto por aquellos que consideraban o que cumplían criterios para algún trastorno de la interacción intestino-cerebro, como para aquellos sin trastornos de la interacción intestino-cerebro, que son en verde, pero además la distensión como tal era solamente la mitad del reporte comparado con la inflamación, y cuando se aplicaron los pictogramas, se pudo ver que aquellos pacientes sin haber reportado inflamación o sin haber entendido este término, también tuvieron un porcentaje presente de estos síntomas. Pero más interesante fue que el que más se logró identificar con los pictogramas fue, como ustedes pueden ver en la gráfica inferior, la distensión abdominal, lo cual implica que este término efectivamente no es comprendido, y en nuestra población inflamación es el término más utilizado. Sin embargo, no lo diferencia entre la subjetiva y la objetiva. La siguiente, por favor. No sirve. Recordemos ahora que estos síntomas, si bien pueden estar en la población general, también hay una entidad que se clasifica como la distensión abdominal funcional, que debe incluir ambos criterios que se muestran aquí: distensión abdominal subjetiva o visible recurrente, que ocurre al menos un día a la semana en promedio, y la distensión subjetiva o visible predominan sobre los demás síntomas, y hay criterios insuficientes para síndrome de intestino irritable, estreñimiento funcional, diarrea funcional o síndrome de distrés postprandial. De entrada, esto nos dice que probablemente estos síntomas de distensión también están presentes en otros trastornos como el síndrome de intestino irritable y la dispepsia. Y este segundo estudio, derivado de aquel primer estudio que les mostré entre Estados Unidos, Gran Bretaña y México, se analizó precisamente lo que ocurría con estos síntomas en síndrome de intestino irritable, en el cual 18.5% de los sujetos lo presentaban, dispepsia funcional sola, que fue el 50.9%, y síndrome de intestino irritable más dispepsia funcional 30.6%, y quiero que se enfoquen en las gráficas de aquí arriba, donde efectivamente esto era más frecuente que en los controles o aquellos que no cumplían criterios para estos trastornos, pero sobre todo cuando había la combinación de síndrome de intestino irritable y dispepsia funcional, estos síntomas eran frecuentes entre estos sujetos que llenaban criterios para estos trastornos. La siguiente, por favor. Pero hay que recordar que hay múltiples mecanismos que pueden ocasionar la distensión abdominal, desde intolerancias alimenticias, puede haber también la disinergia abdominofrénica, sensibilidad visceral, sobrepoblación bacteriana, del cual nos han hablado previamente de una manera muy completa, la disbiosis colónica, anormalidades en la motilidad, desórdenes del microbioma colónico también y alteración en el piso pélvico. Y vamos a tratar de entender cómo aproximar cada uno de estos trastornos desde el punto de vista de diagnóstico y tratamiento, y quizás la mejor forma de poder manejar a nuestros pacientes es poder identificar la causa subyacente que está produciendo esta distensión. Siguiente, por favor. Y este diagrama que fue publicado hace 2 años por Baha Moshiri y el doctor Drossman sobre cómo debía ser el algoritmo diagnóstico y tratamiento de la distensión abdominal, parece enfocarse en cada una de estas posibles etiologías de la distensión y cómo debe ser la aproximación diagnóstica y el tratamiento. Pero quizás, si bien esto tiene cierta aplicación en nuestra población, aquí hace falta algo con lo que nosotros sí contamos y que no cuentan en Estados Unidos. Siguiente, por favor. Y es el uso de antiespasmódicos, que nosotros tenemos una gama de antiespasmódicos con los cuales quiero empezar, que no están disponibles en estos países. Y este metaanálisis que publicó el doctor Francisco Bosques, que hace un rato estuvo aquí haciendo una presentación, demostró que estos antiespasmódicos también tienen un efecto sobre la distensión abdominal y quizás para nosotros son una primera línea de tratamiento, incluso cuando están combinados con simeticona, como se muestra aquí, donde dice la S. Esa es una posibilidad que nosotros podemos hacer de primera línea. Siguiente. Y si me regresan al anterior, por favor. Y aquí hay un estudio que fue realizado en Francia, donde esta combinación a demanda de citrato de alberina más simeticona demuestra que en un seguimiento de 6 meses es un tratamiento efectivo en estos pacientes, como pueden ver ustedes aquí, en comparación con el tratamiento usual, es decir, 3 veces más efectivo en cuanto a la mejoría de este síntoma y por supuesto otros síntomas, pero empiezan a notar ustedes cómo la mayoría de estos estudios están realizados en síndrome de intestino irritable y unos pocos en dispepsia funcional. Hace algunos años publicamos una revisión en el Alimentary Pharmacology and Therapeutics y puedo decir yo que hasta el día de hoy no ha cambiado esto. En realidad no hay en este momento estudios clínicos que se enfoquen o ensayos clínicos que se enfoquen específicamente en distensión abdominal. Y lo mismo con el bromuro de pinaverio combinado con la simeticona, demostró una efectividad a partir de la 2ª semana que fue superior al placebo en estos pacientes, pero interesantemente es cómo hace estos antiespasmódicos. Y hay un estudio que fue publicado hace unos 2 años donde demuestran que el bromuro de pinaverio probablemente tenga un efecto regulador del microbioma. Por un lado, disminuye la formación del biofilm que tiene Staphylococcus aureus y además la presencia de estas células persistent que son Staphylococcus aureus que pueden permanecer allí en este biofilm. Entonces, una teoría muy interesante. Pero si estamos ante pacientes con síndrome de intestino irritable con estreñimiento, ellos también tienen esta asociación con distensión subjetiva, como vimos hace un rato en el estudio de Gran Bretaña, Estados Unidos y México. Y aquí el grupo del doctor Alex Ford, aquí presente, hicieron este metaanálisis y esta revisión donde demostraron que todos estos medicamentos que habían estado aprobados para el manejo de síndrome de intestino irritable con estreñimiento, como linaclotida, lubiprostona, tegacerote en aquel momento y tenapanor, fueron efectivos para la mejoría de estos síntomas, pero aparentemente la linaclotide fue el primero o aquel que produjo la menor falla en reducir los síntomas de distensión abdominal. Pero hay que tener en cuenta que hay ciertas alteraciones que también pueden estar presentes en síndrome de intestino irritable con estreñimiento o inclusive en estreñimiento crónico que pueden desencadenar esta distensión y que tenemos que diagnosticar y tipificar y poder manejar al paciente. Por ejemplo, puede haber un tránsito colónico lento o más específicamente puede haber un retardo o una obstrucción en el tracto de salida que podemos determinar con un estudio de marcadores radiopacos. Por supuesto, la manometría anorrectal nos permite identificar situaciones como una disinergia del piso pélvico y más específicamente la presencia o el estudio de una defecografía por resonancia magnética o en su defecto una defecografía funcional, si es lo que está presente, para determinar si hay esta alteración. Y ante la presencia de una disinergia del piso pélvico, por supuesto, el tratamiento sería hacer una biorretroalimentación. Y les quiero mostrar este estudio que fue publicado en 2022, donde tomaron pacientes después de dieta de 2 semanas para tratar de mejorar la distensión subjetiva, y los no respondedores, que fueron casi 2/3 partes, se les aplicó una prueba de expulsión de balón. 64 de ellos fallaron a la expulsión de balón, lo cual sugería que estos pacientes tenían probablemente un trastorno de la evacuación, y esto fue más frecuente entre aquellos que tenían una distensión abdominal subjetiva mucho más grave. Estos pacientes fueron llevados a biorretroalimentación y 63% de ellos, y más de la mitad respondieron a esta terapia de biorretroalimentación, y todos ellos que respondieron reportaron una disminución de la distensión del 50%, por lo menos en la gravedad de la distensión, lo cual nos hace pensar que es muy importante descartar estos trastornos para mejorar este trastorno y puede mejorar la distensión. Por otra parte, hay ciertas intolerancias alimentarias y hay que siempre mencionar a la enfermedad celíaca, que otra vez, en nuestro caso, si nosotros hacemos el diagnóstico de enfermedad celíaca, obviamente requerimos la confirmación también con el daño estructural, y recordar que hay un grupo de pacientes con síndrome de intestino irritable que también refieren síntomas con la ingesta de gluten. Muchos de ellos tienen una sensibilidad al gluten no celíaca, y probablemente en estos también se requiere la dieta de eliminación para poder mejorar los síntomas de distensión, pero recordar que muchos de los pacientes que nos consultan refiriendo sensibilidad al gluten, en general lo que tienen es una intolerancia a los fructanos más que a el gluten por sí mismo. Y por supuesto, la mala absorción a los carbohidratos fermentables como monosacáridos y disacáridos. Y en este estudio que fue publicado ya hace algunos años, ustedes pueden ver también cómo en todos estos trastornos de la interacción intestino-cerebro, desde síndrome de intestino irritable, los diversos subtipos, la dispepsia funcional y la distensión abdominal funcional, tienen la presencia de estas intolerancias. Claro, esto resulta muy difícil hacer una dieta que elimine estos componentes de la dieta, es decir, los FODMAPs, y quizás la mejor forma de diagnosticarlas consiste en una restricción dietética de 2 semanas, y la resolución de los síntomas nos va a indicar si efectivamente es la causa de la distensión. Pero debo resaltar aquí este estudio reciente, que es un preliminar, donde evidentemente se ve que esta mejoría de la distensión también se logra con estas dietas simplificadas de fructanos y galacto-oligosacáridos en vez de una dieta clásica, o son exactamente igual que una dieta clásica libre de FODMAPs. Y aunque he puesto aquí en el título estudios de imagen, hay que tener en cuenta que también el vaciamiento gástrico por medicina nuclear es importante. Es un estudio que podemos considerar de imagen o de motilidad, porque este nos ayuda a descartar. Hay un grupo de pacientes que tienen gastroparesia, como lo menciona en el algoritmo de Moshiri y Drossman, que hay que descartar que estos pacientes no tengan este retardo en el vaciamiento gástrico, y no olvidar que las pruebas simples de radiología nos pueden ayudar. Por ejemplo, ustedes pueden ver allá en la parte superior una radiografía simple de abdomen donde se ve que el estómago está dilatado y el colon ascendente está dilatado, el tránsito intestinal que nos permite identificar la presencia de algunos divertículos. Aquí hay un divertículo y aquí hay otro divertículo que probablemente están condicionando la sobrepoblación bacteriana, y por supuesto las consecuencias de cirugías de derivación, como vemos esta Y de Rux que está allá arriba, que también por una asa ciega está produciendo sobrepoblación bacteriana. Pero no olvidar que hay un grupo de pacientes cuya distensión puede estar ocasionada por un tumor abdominal, sobre todo un tumor ovárico, como lo muestro en la tomografía que está en la porción inferior. Y no voy a hablar de las pruebas de aliento y de la sobrepoblación bacteriana, que ya extensamente lo hizo el doctor Marc Pimentel. Recordar que probablemente la distensión abdominal subjetiva es el síntoma clave en SIBO, pero también tener en cuenta que en nuestro medio las pruebas de aliento no están disponibles de la forma que quisiéramos, como tienen ellos, por ejemplo, y nosotros en muchos de nuestros casos tenemos que ir directamente al tratamiento cuando lo sospechamos. Yo entiendo que en Estados Unidos dar un tratamiento con rifaximina de prueba puede resultar excesivamente costoso, y como mostraba el doctor Pimentel, se ha demostrado que la presencia de una prueba de aliento es un predictor para la respuesta a la rifaximina, pero nosotros quizás tenemos el medicamento disponible a bajo costo, y unas 2 semanas de prueba terapéutica nos ayudaría para saber si esa es la causa del paciente, como lo muestra este metaanálisis que muestra la proporción de pacientes con mejoría de la distensión subjetiva en cada estudio, donde se analizó el efecto de la rifaximina. Y no puedo dejar de mencionar la disinergia abdominofrénica. La disinergia abdominofrénica, donde hay esta incoordinación entre el diafragma y la pared abdominal, que cuando el paciente inspira el diafragma desciende, pero en vez de haber una contracción de la pared abdominal hay una relajación, lo que lleva a esta distensión. Una entidad que resulta muy difícil de diagnosticar, pero les muestro un caso de la vida real aquí. Una paciente que me consultó por una distensión abdominal, le pedí que el día que tuviera la distensión más severa viniera y se hiciera una radiografía simple de abdomen, y aquí está la lateral donde ustedes pueden ver que prácticamente no hay gas. Muy probablemente esto era una disinergia abdominofrénica, así la manejé, le empecé tratamiento con duloxetina y la paciente mejoró su disinergia. Entonces, una prueba simple que nos puede ayudar a guiar ese estudio, donde no tenemos todos esos estudios sofisticados que hacen, por ejemplo, en Barcelona. Recordar que en estos pacientes la respiración diafragmática y la terapia cognitiva conductual también puede ser de ayuda. Con esto quiero concluir diciendo que la distensión abdominal subjetiva y visible son problemas frecuentes en la población general, en especial en México. No existe en español un término para bloating o distensión subjetiva, y la distensión como tal es un término muy técnico. Por ello, la propuesta del uso de pictogramas que han demostrado efectividad y mejor sensibilidad y especificidad que los descriptores verbales. A eso me refiero con descriptores verbales: distensión o distensión subjetiva o inflamación. Y la distensión abdominal funcional es una categoría diagnóstica de Roma IV, si bien la distensión subjetiva y o visible pueden estar presentes en otros trastornos como el síndrome de intestino irritable y la dispepsia funcional. Debido a la naturaleza multifactorial de la distensión subjetiva y o visible, un tratamiento exitoso incluye identificar la etiología, la gravedad, y con eso poder hacer una educación y reafirmar el carácter benigno de estos trastornos y establecer las expectativas reales de mejoría, no de curación. Y eso lo podemos discutir en la mesa redonda. Y no existen ensayos clínicos que hayan valorado tratamientos específicamente en pacientes con distensión abdominal, y la mayoría lo han hecho como variables secundarias en ensayos de síndrome de intestino irritable y distensión. Como estamos en una sesión y en una mañana de la neurogastroenterología, quiero aquí recordarles que el próximo año, entre el 5 y el 7 de noviembre, se llevará a cabo en la ciudad de Bogotá, Colombia, el Congreso de la Federación Mundial de Neurogastroenterología y Motilidad, por primera vez organizado por la Sociedad Latinoamericana de Neurogastroenterología, donde no solo trataremos todos esos temas, sino muchos de los expertos a los cuales ustedes han escuchado el día de hoy estarán presentes y ojalá nos puedan acompañar en esta reunión. Muchas gracias.
Muchas gracias, Max. Excelente presentación. Sofía, preséntanos al próximo expositor.
Muchas gracias, doctor. A continuación les presento al doctor Alexander Ford. Él es catedrático y gastroenterólogo, consultor honorario en el Hospital Universitario St. James, Leeds, de Reino Unido. Y él nos presentará el tema de tratamiento personalizado del síndrome intestino irritable. Muchas gracias.
Muchas gracias. Thank you for inviting me to speak again in your beautiful country. Just wait for my slides. So I've been asked to talk about personalised treatment of irritable bowel syndrome. I'm looking at the clock and I've already lost 5 minutes on my scheduled duration here. So I'm going to run through things pretty quickly by the looks of it. So that's my disclosures. And the objectives, I'm going to discuss classification systems for IBS and review possible new approaches to subgrouping it. We'll revisit current, and by that I mean American Gastroenterological Association guidelines for IBS. I'm going to summarise the evidence for effective treatments in IBS from RCTs, meta-analyses and network meta-analyses, and I'm going to show how this might be able to be applied to develop a personalised approach to treatment and highlight future research that's needed. So, I mean, this is technically quite heretical thinking, and people in the audience may disagree. There are other approaches available, of course. I'm looking at Professor Tack as I say that. So we know that IBS is conceptualised as a DGBI. It's a chronic relapsing and remitting condition characterised by abdominal pain in association with either altered stool form or frequency, and we're encouraged to make a symptom-based positive diagnosis supplemented by what I would term judicious investigations, so ruling out conditions like celiac disease, inflammatory bowel disease, and possibly bile acid diarrhea, but we're not suggesting that we should investigate people exhaustively to reach a diagnosis. We know that according to Rome 4 criteria, IBS is subgrouped according to stool form and or frequency. So we have IBS-C with constipation, IBS-D with diarrhea, IBS-M with a mixed bowel habit, and IBS unclassified where people do not fall into either of the into any of the other three categories. So I think there's some problems with this classification system. So if we look at the algorithm for treatment, which looks, sorry, apologies, rather garish colours here now. Anyway, this is the AGA treatment algorithm. And you can see that after first line treatment, it immediately branches off according to bowel habit into C and D. So when we look at the efficacy of licensed treatment based on stool subtype according to the FDA composite endpoint, these are the drugs that are licensed currently for IBS-C, and you can see that there are 4 and that the therapeutic gain over placebo in randomized trials is around about 10 to 15%, which I would suggest is quite modest. Similarly, for IBS-D, these are the available drugs in various parts of the world. Remember that remositron is not available in North America or Central America. It's a drug that's used in Japan. But again, therapeutic gain over placebo in these trials is between sort of 6 and 20%. But when we come to IBS-M, who are quite a large subgroup of patients, we don't have any licensed treatments and we don't know whether they're of any benefit. So I would suggest that might be an issue. The other issue is that stability of IBS is known to be poor over longitudinal follow-up. So this is a 12-month study showing that around about 3/4 of people with IBS-D or C are stable, but the others will fluctuate. And for IBS-M, it's less. It's around about 2/3 of people who will be stable. And we know that there is a psychological comorbidity in people with IBS. This is another study from our group showing looking at 5 different markers of psychological health in people with IBS, and you can see that with abnormal scores, the number of domains on the psychological profile that were abnormal, as you increase from 0 to 5, you can see that symptom severity increases in a stepwise manner. according to the number of psychological comorbidities. And people with IBS are much more likely to report extraintestinal symptoms than those without IBS, but who will report other GI symptoms. So this is the PHQ-12, and you can see that all of these symptoms, nearly all, are much more common in people with IBS. So I would say these are the issues. We know that only about 1 in 4 to 1 in 3 patients will respond to drugs that are licensed, and that the therapeutic gain is modest. There's no licensed treatments for the 40% of people or so who have IBS-M or U. So those patients are disenfranchised from research and they don't get included in the management paradigm, and we know that stool subtype fluctuates. Psychological comorbidity is common, but we don't consider that at all in our conventional subgrouping system, despite the fact that it probably determines symptom severity and may impact on prognosis. And again, extraintestinal symptom reporting is common in people with IBS, but is not part of the subgrouping system. So can we personalise treatment in IBS? So this is kind of the holy grail in IBS. If you had the patients with IBS, this is kind of like the, people may recognise this as being a parody of the Pink Floyd album cover, Dark Side of the Moon. So if you have the white beam of light that is IBS being refracted into its different constituents, and these are what we would call endotypes, and this is how the management of asthma and the classification of asthma is now viewed or visualized. So we can do this with one of the techniques that we could use is a technique called latent class analysis, which is a complex statistical technique that applies modeling to multivariate data to observe, to create unobserved groups, or what we call latent classes in the data. And that data is fitted the best it can be using statistics to the data sample. And you can include a wide range of variable types, anything you want really in the model, and multiple solutions to the data set are computed and the best output is selected using robust criteria. And we and others have done this, and this is our model, but others have done other models using different variables, but the models come out with relatively similar groups. So this is our model of the analysis of 811 people with Rome 4 IBS. And you can see that in our analysis, we do actually get 7 clusters conveniently. The top cluster is diarrhea and urgency with low psychological burden. That's the red cluster. The orange cluster are those with generally low bowel symptom severity, but quite a lot of pain and high psychological severity. The yellow cluster are those with both low GI and low psychological symptom severity. Then you go on to the higher psychological severity clusters 4, 5, and 6. 4 is diarrhea, pain and urgency with high psychological burden. 5 is constipation, pain and bloating with high psychological burden. 6 is basically they report all symptoms irrespective of whether they are GI or non-GI. And then 7 is a lower psychological burden cluster, mainly with constipation and bloating. So this is conventional subgrouping of IBS, but I would argue what we're really looking at with IBS is it's a 3-dimensional model, really, where you have constipation and diarrhea, but also you've got this third dimension, which is pain and psychological burden and extraintestinal symptom burden. And you can map the clusters onto this, so you can see that at the bottom left is the low GI symptom severity and low psychological burden, the constipation and bloating with low psychological burden, the purple cluster, the red cluster, diarrhea and urgency, low psychological burden. And then as you move backwards on the prism, you can see you've then got constipation, pain, bloating, high psychology, diarrhea, pain, urgency, high psychology. The purple cluster, who basically report all symptoms and have got lots of psychological burden. And then tucked away at the back, the orange cluster, who've got low GI severity, but high pain and high psychological burden. So how can we approach treating these patients? So if we think about first-line advice, which you might be applying to something like the yellow cluster, who've got generally low symptom severity, and looking at the AGA guidance, we're thinking about education, lifestyle modification, diet. So this is from Magnus's group, showing that education in a randomized controlled trial in people with IBS can improve symptoms over and above written information. And this is another study from Magnus looking at exercise in a randomized trial. So 75 patients, and although this trial did not show a significant difference, you can see that there was a benefit of physical activity administered by a therapist over a control in terms of improvement in symptoms. And when we think about first-line diet, this is our updated network meta-analysis of various dietary therapies in IBS, over 2,000 patients. And you can see that the first-line dietary advice, BDA or nice diet that many of us use, is actually superior to a habitual diet. I've highlighted it in the red box. And so the relative risk of symptoms persisting with a BDA nice dietary advice is lower than with a habitual diet. So it's an effective treatment. And then we've got soluble fibre. So if we think about Ispagula, this is our meta-analysis from a few years ago now showing that Ispagula was superior to placebo for global symptoms in IBS. So these are all reasonable first-line treatments for people with less severe symptoms. What about specifically constipation and bloating? So here we've got we're going down the left-hand arm of the AGA guideline, and we're talking about things like laxatives, secretagogues, and also Tegaserod, which at the time this guideline was produced, Tegaserod had been reintroduced, but it's since been withdrawn. So here's an RCT of polyethylene glycol. There are only 2 RCTs, and this is probably the best one in patients with IBS with constipation. And you can see that although this doesn't use stringent FDA endpoints, you can see that the mean number of complete spontaneous bowel movements is improved at 4 weeks with PEG, polyethylene glycol, and you can see that also the overall response to treatment at 4 weeks is significantly higher. If we think about the trials that there have been of licensed drugs, because of the way the FDA constructs its endpoints, we can actually look at whether these drugs are effective according to the composite endpoint, but we can also split that because the trials report whether they improve pain or whether they improve stool frequency for constipation or stool consistency for diarrhea. So this is looking at stool frequency. And you can see that the drugs that we have available, most of them are effective: linaclotide, tenapanor, plecanatide, not so in this analysis. And you can see that linaclotide, 290 micrograms, was the drug that was ranked the highest, the most likely to be the best drug. There were no data available for stool frequency for lubiprostone in this network meta-analysis. This is from our group. And if we look at bloating, Max showed this slide earlier. This is the efficacy of licensed drugs for bloating, and you can see all of the drugs actually were effective in this analysis, but there were no bloating data available for plecanatide. And we've got to remember that there's another drug, prucalopride, which is not licensed for treating IBS with constipation, but it is licensed for constipation, and that's a very effective drug, unequivocally effective in this meta-analysis, lots of trials, lots of data. This is a drug that, in terms of stool frequency, complete spontaneous bowel movements, is effective. What about treating diarrhea and urgency? So now we're going down the right-hand limb of the AGA management algorithm. So we're thinking of drugs like loperamide. I'm not going to talk about bile acid sequestrants because I don't think there's any randomized trials of those in IBS with diarrhea, and they're a treatment for bile acid diarrhea. We'll also talk about rifaximin, tricyclics, elaxadeline, and 5-HT3 receptor drugs like elocitron. So this is the evidence for the efficacy of loperamide. This is from the ACG monograph 10 years ago, where we found 2 randomized trials, one of which was beneficial, the other not, and when you pool the results, there is no evidence for an efficacious effect of loperamide in IBS with diarrhea, but in 42 patients. So we use this drug obviously all the time, but there is little evidence. This is data from the Atlantis trial, my trial of amitriptyline in IBS, splitting the efficacy according to subtype, and if you concentrate on the middle part of this chart, you can see that the effect, the magnitude of the effect between placebo and amitriptyline low dose, between 10 and 30 milligrams, was higher in those with IBS-D than in C or M or U. And then if we look at licensed drugs and stool consistency, so on the Bristol Stool Form scale, you can see in this network meta-analysis that all drugs were more effective than placebo, including rifaximin and elaxadeline, but elocitron and ramositron were the 2 top-ranked drugs, and elocitron was highly likely to be the most effective treatment. There's also another 5-HT3 receptor drug that we can sometimes use because we don't have access to elocitron and ramocitron in some countries, and that's ondansetron. So this is our meta-analysis of 3 randomized trials of ondansetron in terms of its effect on stool consistency, and you can see that this again is an effective drug in these 3 trials. And ondansetron can also help urgency. This is the impact of ondansetron on urgency in these 3 trials, statistically significant to placebo. So we can plug the data of ondansetron into our previous network meta-analysis, and you can see that this now looks like a class effect where the 5-HT3 drugs are all coming out top for improvements in stool consistency. There's also this treatment, which some of you may be aware of, which is called Enterose gel, which is an intestinal absorbent. This is a big trial from Jan Janikow in the UK, showing that Enterose gel was superior to placebo, both for the FDA stool consistency endpoint on the left, but it also improved urgency. It reduced the mean urgency score significantly in this trial. So this is another thing to bear in mind. And this is our updated network meta-analysis, showing that a low FODMAP diet in these trials that I showed you earlier, in only the trials that recruited patients with IBS with diarrhea, low FODMAP diet is a effective treatment and is superior to habitual diet. Gluten-free diet and tritodium-based diet came out higher, but these were studied in single RCTs, so the most robust data there are for the low FODMAP diet. What about treating abdominal pain and psychological comorbidity? So all of these drugs can actually have effects on pain because, as we know, pain is measured as an endpoint in these licensed trials, but we can also talk about antispasmodics and peppermint oil. So this is the evidence for an effect of antispasmodic drugs on abdominal pain in our meta-analysis. You can see there's a lot of heterogeneity between these trials. I think it's hard to know which of these drugs is particularly beneficial, and although the pooled result is in favour of antispasmodics as a class, I don't think we know which antispasmodics are beneficial particularly, and there are issues with availability. As Dr. Schmulson was mentioning earlier, some of these are not available in other parts of the world. What about peppermint oil, which is another antispasmodic? So again, this is our meta-analysis showing that peppermint oil is superior to placebo. This was updated 2 or 3 years ago. I would point out, though, that the more recent trials and the more rigorous trials actually are showing no particular benefit of peppermint oil. So although there is still an overall benefit in the meta-analysis, that benefit is becoming increasingly modest as more trials are published and are incorporated in it. This is another updated meta-analysis published recently looking at the effect of tricyclics on abdominal pain. So these are the trials that reported abdominal pain, so 700 patients, and you can see that there was a benefit of tricyclics. Similarly, licensed drugs, we can get the 30% improvement in abdominal pain from these data, and this is the network meta-analysis looking at the effects on pain in people with IBS-C. And you can see again linaclotide comes out top, tenapanor, procanatide lower down. Ondansetron had no effect on abdominal pain in our meta-analysis, so I don't think this is a drug that is going to benefit patients with diarrhea with pain, but it will improve urgency and stool consistency. So I haven't updated the network meta-analysis here for the effect of licensed drugs on pain in IBS-D. These are as they were in our original network, and you can see again all the 5-HT3 drugs come out top. Elaxadeline 100 milligrams seems to be efficacious, not so much rifaximin, and elaxadeline 75 milligrams BID also non-efficacious. So then for patients with persistent pain and abdominal pain and psychological comorbidity, there's a recommendation to add in or switch to low-dose tricyclics. Think about SNRIs, think about gut-brain behavioural therapies. So we'll just go through the evidence for those. So this is just showing the effect of amitriptyline on pain in the Atlantis trial. It's important to point out that actually it took some time for that benefit to be realised. At 3 months, there was no significant effect over placebo, but by 6 months, there was quite a therapeutic gain, and that was highly statistically significant. This is a small Iranian study looking at venlafaxine and SNRI, and you can see that there was a benefit of venlafaxine over placebo, not just for frequency of abdominal pain, but also the onset of pain in both patients with IBS with diarrhea and also the onset of pain in patients with IBS with constipation. This is another network meta-analysis from our group looking at the effect of brain-gut behavioural therapies or psychological therapies or behavioural treatments, whichever your preferred terminology is, on abdominal pain specifically in over 5,000 patients. And you can see on the forest plot that the studies, the therapies at the top are generally the ones that have been studied in small trials and show extreme results, but the larger the green square on the plot, the more data there are, and you can see that the most evidence exists for forms of CBT and gut-directed hypnotherapy in this network meta-analysis. So these are beneficial treatments for pain. There's also some evidence for augmenting treatment, augmenting therapy in chronic pain, so combining neuromodulators. So this is a small uncontrolled study from the UK, but it shows that if you're combining more than one neuromodulator for abdominal pain, it's more effective than a monotherapy, highly statistically significantly so. In terms of treating psychological symptoms, this is our Atlantis study again, showing that actually low-dose amitriptyline didn't have any significant benefit over placebo for HAD scores or PHQ-12 scores in the trial. So we weren't improving mood at this dose, we were only improving gastrointestinal symptoms. But this is data from Professor Tack's randomized crossover trial of citalopram, showing that HAD scores did improve both anxiety and depression with citalopram versus placebo in this smaller study. And this is an uncontrolled study showing quite nicely that with duloxetine in patients with IBS and comorbid depression, as their GI symptom severity came down, their depression scores came down as well. This is from the ACTIVE study, which is a big trial of cognitive behavioural therapy, again showing that CBT, either via the telephone or via the web, the internet, was superior to treatment as usual for its effects on HAD scores at 3, 6, and even sustained out to 12 months. And then this is a trial from Australia showing multidisciplinary care was superior to standard care for patients with DGBI. So this is for patients with severe symptoms with psychological comorbidity. Combining therapies like this in a multidisciplinary setting is more effective than just seeing a gastroenterologist alone. So can we move towards personalised therapy in IBS? I'm going to summarise now. So these are the clusters that I mentioned earlier, the 7 clusters that I showed you, but others have reported slightly different clusters, although the themes are the same. So if we go around them, starting with cluster 1 in clockwise order, so we've got the cluster with diarrhea, urgency, and a low psychological burden. I would suggest there the first line treatment would be something like loperamide or enterose gel, but second line you could consider low FODMAP diet if they don't have any evidence of restrictive eating, a tricyclic at a low dose, aloxadeline or rifaximin, because they're not going to be of much benefit for pain. For cluster 2, where GI symptom severity is lower, but they've got pain and psychological comorbidity, again, you might think of a TCA first line or even an SNRI, and second line considering adding in a brain-gut behavioural treatment. For the third cluster, the yellow cluster, who've got low GI symptom severity and low psychological severity, they may well respond to just explanation, reassurance, education, lifestyle measures, or simply first-line treatments like an antispasmodic or an antidiarrheal or a laxative. Cluster 4, urgency, pain, diarrhea with higher psychology. So there you're going to be thinking of drugs that would improve pain first line, like a losatron, ramosatron, or a low-dose tricyclic, and perhaps adding in or switching to an SNRI and a brain-gut behavioural treatment as second line. For the ones with constipation, bloating, pain, and high psychological burden, first line would be a secretagogue, because I've shown you they can improve pain as well as bowel habit, but second line you might want to add in something like an SNRI, which can improve pain in people with IBS with constipation, or again consider a brain-gut behavioural treatment. The group that have got all symptoms and high psychology, all bets are off how you manage those, I think. But first line might be augmenting treatment with multiple gut-brain neuromodulators, multidisciplinary care, as I've shown you from the MANTRA trial, and perhaps adding in brain-gut behavioural treatment. And then the last group, who are probably quite an easy group to treat, constipation, bloating, low psychological burden, I'd think about using a laxative first line there, or maybe prucalopride, because I've shown you that can improve stool frequency. And second line, you might want to switch or add in a secretagogue. So what's the current state of play? I think we're in a similar situation actually to the IBD clinicians, where we've reached the therapeutic ceiling, so they're now consistently talking about combining immunomodulators or combining biologics, but we've reached the therapeutic ceiling in IBS as well. The gains that we can produce with novel therapies over placebo are modest. I think we need new approaches to treating patients with IBS. I think reclassifying IBS using latent class analysis has got some advantages. It's intuitive, it reflects the heterogeneous nature of the condition, it incorporates the psychological comorbidity. I've shown you that evidence-based treatment, according to all these meta-analyses and RCTs, can be mapped to the clusters that I've described. I apologise, I've had to go through that in quite rapid order, but it may allow more nuanced treatment. And I think, it's unlikely if you're seeing a patient in Group 4 who's got high pain, high urgency, high psychological burden and diarrhoea, that they're going to respond to loperamide, whereas a patient in Group 1 who's just got the diarrhoea and urgency may well do. So this treatment paradigm could improve outcomes, but obviously in terms of further research, we need other people to replicate these clusters, and we need real-world studies to show that the behaviour in response to treatment in these clusters differs between them. So I'm going to finish there. I'm 2 seconds over, apologies, and thank you very much for asking me to speak.
Muchas gracias, Dr. Ford. Quisiéramos invitar a los médicos que están parados al fondo. Acá hay lugares, por si no quieren cansarse más de la hora que ya han estado parados.
Nuestro último expositor es el doctor Jan Tak, presidente de la Fundación Roma para el estudio de trastornos de interacción intestino-cerebro. Él es jefe de la División de Gastroenterología y Hepatología del Hospital Universitario de Leuven, Bélgica, y es director del Centro Translacional de Investigación para Trastornos Gastrointestinales y que forma parte del Departamento de Enfermedades Crónicas y Metabólicas de la Universidad de Leuven. Bienvenido nuevamente, Dr. Tak.
Thank you for inviting me to the lecture, to this meeting to lecture here, as I already said this morning. However, in this session I feel a little bit out of place because the topic is prokinetic, and to me this looked like a bowel session, and prokinetics are usually addressed in the upper GI tract, but let's see what we made of it. So I adapted the initial slide to the meeting and I adapted the content a little bit. So what are prokinetics? Very simple, drugs to promote or enhance or restore good, well-coordinated gastrointestinal motor function to stimulate propulsive activity. And so they act on the peristaltic reflex, which is actually the basic activity that the enteric nervous system coordinates. If you take out a piece of bowel and you put it in an organ dish and you put a distending pellet into it, it propels. The pellet doesn't even realize that the rest of the animal is gone, and does so at a very specific speed and coordination. And this is because there's a nervous system, the enteric nervous system, which is hardwiring this with a sensory system, an ascending contractile limb, a descending inhibitory limb, and many, many neurotransmitters in there. So this is the target for improving peristalsis. And historically, there have been several prokinetics, and they are lumped under one umbrella, but actually, if you look at these, and this, as illustrated, comes really from gastric physiology and pharmacology, all of them will stimulate gastric emptying. That makes them prokinetics, but they have very different molecular and pharmacological targets, 5-HT4, dopamine 2, cholinesterase, motilin receptor, and they have various combined other activities like antiemetic, effects on visceral sensitivity, or on fundic accommodation. And there's a couple of classical, well-known drugs in there. So where can we use them? Let's start in the esophagus. We heard this morning from Ronnie Fass that ineffective motility is very, very often seen. And these are some of the images of failed or weak peristalsis. And the contractile function is not enough. You would think, let's stimulate this with a prokinetic. And this has been tried. This is a review we wrote 10 years ago now looking at all of the agents that have been tested in ineffective esophageal motility, and most of them are not effective. Let's illustrate one or two principles. So if you simplify the enteric nervous system, you have excitatory motor neurons, which will release acetylcholine and substance P probably, and inhibitory ones, which will release nitric oxide and VIP. And acetylcholine is a very dangerous agent, so when it's released, it's immediately degraded by cholinesterase, and by cholinesterase inhibition, you can enhance its activity. And in the esophagus, it seems that there's a 5-HT1A receptor presynaptically on the nitrogen neuron and actually inhibiting relaxatory function. And so hydrophonium is a short-acting injectable cholinesterase inhibitor, and that actually is able to improve the percentage of ineffective motility, ineffective peristalsis in patients with mild ineffective motility, and in those with severe, there's a subgroup who responds, but a subgroup who does not respond. However, this is an acute IV administration study. There's very, very little done in terms of chronic use, but this is with pyridostigmine, orally available cholinesterase inhibitor, and this study actually shows in healthy volunteers enhancement of peristaltic amplitude. This is an old study using standard esophageal manometry. This was not high resolution. And buspirone, a 5-HT1A agonist in healthy volunteers in our hands, acutely enhances peristaltic amplitude. Again, this is old school standard esophageal manometry. And this is done in a group of patients with systemic sclerosis, so some of the most difficult patients. And this study from Greece failed to show enhanced peristalsis, only showed increase in LES pressure. So far, we don't have any evidence that any of these stimulatory agents improve the symptoms of patients with dysphagia due to ineffective motility. The other obvious target is PPI refractory GERD. And this is an old analysis looking at some of the prokinetics that were added to people who were insufficiently controlled for reflux disease with anti-secretory agents. Now, to the left here are H2 blockers. And these are studies with cisapride, old studies. The placebo, the PPI or the acid suppressive drug alone is dark, and the light green is added to prokinetic, and then there was a gain. But after that, with PPIs, adding other prokinetics, you always get a numerical higher response, but never statistically significant. So this is all. This is summarized in 2016. Since then, we have seen revexapride. This is another 5-HT4 agonist that was studied in two studies, one in North America and one in Europe. And actually, although in the first study in the US, the dose-finding study, there was a hint that perhaps the 0.5 milligram in green might be effective, the subsequent large European trial negated that effect. So this is bad news. Prokinetics in the esophagus to restore ineffective motility, no evidence of any efficacy. And for PPI refractory GERD, no evidence of any efficacy of adding a prokinetic to the PPI. This is a bowel session, so let's look at bowel disorders. And here 5-HT4 agonists come into play, and the receptor is expressed on excitatory motor neurons, enhancing the release of acetylcholine, stimulating contractility, and probably also a direct relaxatory effect has been claimed on intestinal smooth muscle. We don't know whether that is there in humans. And the first class of 5-HT4 receptor agonists were the benzamides, and the best known of these was cisapride, and cisapride in our field is the really only game changer, blockbuster drug that we ever had, but it was removed. Efficacy was shown in GERD, mainly for nocturnal heartburn. This is where it was approved for. It was introduced worldwide in the 90s, probably used and abused for all motility disorders, and maybe mostly used for dyspepsia and gastroparesis. And there was some weak studies showing some efficacy there, but it was associated with QT prolongation, fatal arrhythmias through actions on the Hurk channel, and it was withdrawn in 2000-2002. Then two new classes of 5-HT4 receptor agonists were created. The carbazimidamides, of which tegaserod is one, velucetrac is another one, and then the benzofuran carboxamides, of which prucalopride is a member. And these are very, very different, because if you look here, cisapride had efficacy on the 5-HT4 receptor, but also 5-HT3, 5-HT2, and the hERG channel, whereas the new generations here, tegaserod, velucetrac, prucalopride, they have high selectivity for 5-HT4 for these two, but tegaserod also had some affinity for 5-HT1 and 5-HT2. So that got us in a realm of more selectivity. So what is the efficacy spectrum of these classes, the 5-HT4 agonist in the lower GI tract? Prucalopride is extensively been tested, as you also saw in the previous talk, for chronic constipation, both in males and females. It has a significant and robust and reproducible effect over placebo. The cardiovascular safety of these newer agents is excellent. This is a study we did, we published 2 years ago, looking at literature review, post-marketing surveillance, in vitro data, clinical data, and actually there was no hint of any cardiovascular risk of prucalopride. In Europe, this was well known. Prucalopride has been on the market for 15 years. In the US, it took the FDA 10 years longer to realize that perhaps it was cardiovascularly safe, and now they have it in the US as well. The effect on constipation is a class effect. These are all 5-HT4 agonists. It goes from tegaserod over prucalopride to velucetrac and naronapride. The white is the placebo. The colored are different dosages of these drugs, and you see a very robust, consistent class effect in inducing response in terms of complete or spontaneous bowel movements over placebo or over baseline. So a very, very strong effect. If you look in IBS with constipation, this is studies with cisapride, renzapride, and tegaserod. There is a consistent effect, but it doesn't always reach statistical significance. So the class effect of the 5-HT4 agonists here is a lot less pronounced. So if you are a company, you have a 5-HT4 agonist, and you want to show efficacy to get it on the market, probably chronic constipation is your game to enter into. So we have efficacy in IBS and in chronic constipation with these prokinetics. Many others have not been tested in the lower GI tract. Now, most studies are in the upper GI tract in functional dyspepsia and gastroparesis. I will not address gastroparesis because I give a talk at the main meeting on Sunday, so I'll focus on functional dyspepsia. You know the definition. Early satiation, postprandial fullness is the PDS, and this is where the prokinetics will be used. And you've seen, maybe in the previous session, that actually after PPIs, in the American consensus, they propose first a tricyclic before they go to prokinetics. And the reason is that, and sorry for the shrinking accolade there, this should have shown the whole cisapride block, this one. So the bulk of studies actually comes from cisapride, a 5-HT4 agonist. And you've seen this one before. There's a variable selectivity of these agents. So have these been tested in functional dyspepsia? Not so much. There were actually 2 studies with cisapride in functional dyspepsia, which showed a numerical gain, perhaps with the 30 milligram, 3 times 10 milligrams, but actually didn't reach statistical significance. AstraZeneca bought mosapride from Asia, did a large-scale dose-finding study in Europe, which was completely negative. And tegaserod, there were 2 studies done in FD. I think there's a lot of things to say about patient selection and trial design there, and there was a minimal improvement over placebo. So we don't see a class effect of 5-HT4 agonists in functional dyspepsia. And actually, the meta-analysis from the American College and the Canadian Association showed that the PPIs seem to be outperforming the prokinetics, and this is why they were earlier in the ranking. But we have other targets. Dopamine 2, the theory wants that dopamine 2 is presynaptically inhibiting the release of acetylcholine, and so if you block it, you would get more release of acetylcholine. I have to say that this is not well established in human ex vivo tissues, actually, but this is a theory. And domperidone comes to mind, and these are some old studies. Quality is questionable, but there was a suggestion of superiority to placebo for domperidone in functional dyspepsia. Then we have also itopride on the bottom here, which is also a dopamine 2 antagonist, combined with cholinesterase inhibitor. And there were 3 trials there. And then acotiamide is also a cholinesterase inhibitor and a presynaptic muscarinic receptor inhibitor. And this is the pivotal trial, a 4-week trial that was done in Japan that brought it to market in Japan. And this is an interesting trial because if you look at the response rate, this is the placebo, 4 weeks. This is the active drug, 3 times 100 milligram. And then the treatment was stopped, but actually the difference was maintained. We haven't seen this in any other trial in functional dyspepsia. So this seems to be working. Oh, and something went wrong here. Let's skip this one. Yeah, then there was a long-term study in Europe with acotiamide, 3 times 100 milligram, showing improvement of the cardinal symptoms of functional dyspepsia, satiety, fullness, and upper abdominal bloating, and improvement of quality of life and in work and productivity performance. So this seems to show some efficacy. So in functional dyspepsia, we do have with cholinesterase inhibitors and dopamine 2 antagonists some signals of efficacy. Gastroparesis, there are signals of efficacy, but I will address this on Sunday. So in conclusion, prokinetics, heterogeneous class of agents. Drug development has been difficult. Very few new agents have become available over the last decades. Dose selections is not, I didn't show that, but is not determined by the effect on gastric emptying rate. There's evidence of efficacy, but quality is inconsistent and high variation amongst agents. Many more studies are needed. Is anything happening in this field? Well, over the last 1.5 to 2 years, there's been a new dynamic. Naronapride has just finished its dose-finding study in gastroparesis. What is naronapride? This is cisapride, where the QT prolonging effect was worked out, and dopamine 2 antagonism was added. So I think an attractive pharmacological profile. 320 patients were randomized in this study in 4 arms, and I think the top-line data will be available next month. We'll see whether this drug progresses in the field. This is a 5-HT4 agonist plus dopamine 2 antagonist now. And then Velucetrac is of the class of tegaserot, is a 5-HT4 agonist. There was a study showing its efficacy in chronic constipation, but the company took this into chronic intestinal pseudo-obstruction. There was a very small number phase 2A study showing a hint of efficacy. Only 16 patients were enrolled, and now they are embarking, hopefully, on a longer-term development of this 5-HT4 agonist for probably the most difficult motility patients we have, the chronic intestinal pseudo-obstructions. Thank you for your attention.
Muchas gracias, doctor Tac. Invitamos a los expositores, por favor, a subir al podio y tomar asiento para las preguntas. Les recordamos que tenemos micrófonos a ambos lados del salón y que tenemos tiempo para realizar preguntas. Bien, mientras tenemos una pregunta allí. Adelante, doctor.
Bueno, para preguntarle al doctor Max, hemos platicado con él en forma personal siempre la dificultad que existe entre de separar el dolor abdominal y la inflamación, porque aquí en México efectivamente el paciente se siente inflamado, pero le dice, ¿le duele o es porque se siente distendido? Por eso es que él mencionaba muy claramente el ponerle los pictogramas para tratar de definir esta situación. Y desde luego nos presentó el panorama farmacológico que puede ser útil o que ha demostrado utilidad en estos pacientes. Pero Max, recientemente se ha estado utilizando la neuroestimulación transcutánea sacra o la estimulación abdominal o inclusive el masaje abdominal bien dirigido para tratar de disminuir esta distensión. ¿Tú tienes algún estudio que esté siguiendo de tratamiento con neuroestimulación o conoces algún estudio internacional que esta terapéutica pueda ser utilizada en estos casos?
Muchas gracias por la pregunta. No conozco ningún estudio en distensión abdominal específicamente. Si esa era la pregunta, no sé si alguno tiene algún conocimiento de neuroestimulación en distensión.
Pero mientras hay alguna otra pregunta, yo quisiera aprovechar para preguntarle al doctor Pimentel sobre uno de los, utilizando un término musical, uno de los greatest hits of the year, que fue el trabajo, el abstract que presentó en la DW, en la que se combinaba N-acetilcisteína y rifaximina. En realidad la pregunta, más allá de ampliar un poco esto con lo que nos quedamos ganas de leer, va dirigida a los efectos adversos, porque en realidad la rifaximina es muy noble y hay efectos adversos como diarrea, calambres abdominales, náuseas, vómitos, atribuidos a la N-acetilcisteína. Yo quería saber si en los pacientes que usaron N-acetilcisteína en su estudio se reportaron de manera significativa estos efectos.
The question is N-acetylcysteine added to rifaximin. So what we showed what we showed is that N-acetylcysteine adding to rifaximin improves the gap between the placebo and the drug. So much more effective than rifaximin alone. But didn't see side effects much at all in this study. Remember, it's a small study, so we're now starting a phase 2B study of this product, and so we'll know in a few months. It's very exciting because it's very effective.
Adelante, doctora, gracias.
Muchas gracias a los expositores, excelentes exposiciones realmente de primer nivel. Una pregunta para el doctor Pimentel y para el doctor Ford también. Hablando un poco de intestino irritable y el manejo personalizado, considerando la fisiopatología en cada caso, ¿les parece que tendríamos que entonces meternos un poco a investigar un poco microbiota sobre crecimiento en particular en todos los pacientes con intestino irritable? Si tuviéramos disponibilidad, claro, porque sé que los test no están disponibles en todas partes.
So in my clinic, I saw 30 patients last week, and we work up their microbiome. Our goal is to find a treatable cause of IBS rather than to just simply treat symptoms, because this is what we've been doing for decades. So we do, and we recommend it to our patients. The question is, really, is it cost effective? And so you will see studies coming out that show that starting with the breath test is actually more cost effective than, for example, if you do the breath test, it's positive, higher likelihood to respond to rifaximin. They respond to rifaximin by 70–80%. They don't need any other tests. You save a lot of money. So as the cost effective data comes out, I think it'll be more meaningful to start to think about, should we investigate up front and avoid some costs by not doing other things.
Para el doctor Pimentel, ¿cuántas veces llega a repetir los esquemas de rifaximina en pacientes con síndrome intestino irritable?
So we published a study where up to 6 times that patients had got it over many years. If it worked the first time, it always worked the 6th time, although there were some variability from time to time. So we don't see clinical resistance. Yes, there's a published study that says maybe one bacteria became resistant or these sorts of things, but in general, systematically, there's not evidence for resistance developing or being sustained after rifaximin, and it's been around for 30–40 years already, rifaximin. So we give it as many times as the patient needs it, but obviously we don't want to give it every month. The ideal pattern is you give rifaximin. If they relapse, okay, you give it again, but then you have to take efforts, whether it's a prokinetic, whether it's diet, whether it's other ways to try to sustain the remission rather than just keep giving rifaximin over and over and over again. I don't like that approach.
Sí, esa es mi experiencia también. Yo lo que hago es Les doy el primer ciclo de rifaximina, pero utilizando la dosis de 550 miligramos 3 veces al día por 14 días. Y si el paciente responde pero recae muy rápidamente, lo repito. Pero de ahí en adelante trato, lo que dice el doctor Pimentel, de repetirlo cada vez que el paciente recae, pero trato de que eso no sea antes de 3, 4 meses, y generalmente los pacientes vuelven a responder, y si hay alguna cosa en el inter, manejarlo con un procinético o con un antiespasmódico que les ayude a los síntomas.
But I'll say one last thing, is that if a patient responds to rifaximin, yes, it could be overgrowth, but you have to remember there's a long list of causes of overgrowth. We have found many patients with adhesions, and you just fix the adhesion and they don't need any more treatment. So if a patient needs rifaximin every month, you need to work them up and not just leave it and not just try to manage with diet. It may not be just simple SIBO.
Yo tengo una pregunta para el doctor Tack. Sabiendo que los prokinéticos son también útiles en el manejo de la gastroparesia y considerando una superposición tan importante entre gastroparesia y dispepsia funcional, a día de hoy, ¿cuál sería el espacio, según tu criterio, para procedimientos invasivos en pacientes con gastroparesia como un GPOEM o una piloroplastia?
So I think you don't need a gastric emptying test to use a prokinetic, which is low threshold, well tolerated, and not too expensive. Gastroparesis is associated with symptoms of nausea and vomiting mainly, not with the classical 4 dyspeptic symptoms, but you can use a prokinetic there or an anti-nausea and anti-emetic or a combination of these there. And only patients who do not respond, then I would do the emptying test, and there's a couple of treatments which are more invasive or less well tolerated that have only been tested in patients with established delayed gastric emptying. These include GPO, gastric peroral endoscopic myotomy. All these patients have been selected based on delayed gastric emptying. The vast majority of patients who have received gastric electrical stimulation, so few with normal emptying, but these are a very small subgroup. And then also studies with prucalopride in upper GI conditions have selected patients based on delayed emptying, and prucalopride is more expensive and less well tolerated. And very, very old in the 90s, studies with erythromycin and other macrolides have also selected the patient. So I think you need it probably before you make a step to any of these conditions.
El doctor Eduardo tiene una pregunta.
Gracias. Hay un estudio por ahí de rifaximina en dispepsia funcional posinfecciosa, otro combinado con neomicina en estreñimiento, intestino irritable estreñimiento. Son dos estudios aislados, uno es una combinación con neomicina que es un poquito difícil de en la práctica indicar, pero ¿cuál sería una indicación para probar rifaximina en dispepsia y en estreñimiento asociado a intestino irritable con distensión? ¿Vale la pena hacer una prueba de aliento para bacterias metanogénicas?
So what we see with methane is that it's proportional. So the higher the methane, the more constipated a patient is. So in that case, methane is really important. So I really like to do a breath test in those patients. But then it also guides me to that rifaximin won't work or is less likely to work all by itself. So we give rifaximin with neomycin or rifaximin with metronidazole as a substitute, even though that wasn't the randomized control trial. But in dyspepsia, there's some modest data, but maybe on, the data on rifaximin and dyspepsia.
Yeah, I think in dyspepsia there's only one trial, a trial of Victoria Tan. She took dyspeptic patients who were H. pylori negative and randomized them to placebo or to rifaximin at a standard dose that was established for IBS, and followed the patients up, and there was improvement of symptoms. Not so much of the cardinal dyspeptic symptoms of fullness and early satiation, but there were effects on pain, on upper abdominal bloating, and overall there seemed to be a response. this was not driven by comorbid IBS, so I think this seemed to be a specific upper GI effect. And meanwhile, we've seen data, mainly in the probiotic arena, that targeting the microbiota could be another avenue worth exploring in functional dyspepsia, but it's not ready for prime time.
Doctor Ford, ¿llega a utilizar probióticos en pacientes con síndrome intestino irritable?
Yeah, well, we're not allowed to prescribe probiotics in the UK. I don't know whether that's the case in Mexico or not. But obviously, you know, we have done several meta-analyses of the efficacy of probiotics in IBS, and I presented some of the data on that last year at the meeting. So I tend to tell people with IBS that they could consider a probiotic, but they will have to buy it themselves and pay for it themselves. And I give them the names of probiotics that I know have been efficacious in randomized trials. And I normally advise that they could try them for 8-12 weeks. And if after 8 to 12 weeks there's not been a benefit, then they could switch and try a different one. So some of the ones that I would recommend from our meta-analyses would be, there's combination probiotics, so what used to be called VSL number 3, I think it's now called Vivamax. There's bifidobacterium strains, so specifically Bifidobacterium infantis 35624, I think was the original name, and that's marketed as Align or Alflorex. And then there's a lactobacillus, particular lactobacillus that seems to be beneficial in about 4 or 5 trials. I think that's called DSM 1943 or something like that, or 1983. And then another one that I tend to recommend is Simprove, which is a combination that comes as a fruit-flavoured drink. So I normally, I explain that probiotics are by no means a panacea for IBS, but that they can be beneficial for some people. They can have beneficial effects globally. They can sometimes improve bloating. They can sometimes improve pain.
Pues con esta pregunta cerramos el módulo. Muchas gracias a los ponentes y a los médicos. Gracias.
Solo recordarles, en este momento hay 3 comidas simposio, y si no, a las 3:30 empezamos el último módulo. En el salón 1 está el de pruebas de función hepática con el doctor Lisker, en este salón el de intolerancia a la lactosa y el de endoscopía cápsula en el salón número 5. Y a las 3:30 para los que no los esperamos a tiempo. Gracias.